Good afternoon, everyone. My name is Steve Blount, and it's a pleasure to welcome you to the 7th Annual Jeffrey Koplan Global Leadership in Public Health Lecture. That's a mouthful. We just had a nice mouthful across the street. So, I want to introduce our guests of honor, Dr. Koplan, who was the director of CDC from 1998 to 2002 and is now the vice president for global health at Emory. Would also like to introduce his wife, Dr. Koplan, Dr. Carol Koplan, adjunct professor in the Department of Health Policy and Management at the Rollins School. We also have another special guest here, another former CDC director, Dr. David Sencer. Dave, please stand. And of course, our guest lecturer, Dr. Donald Hopkins. You'll see in your programs that Dr. Hopkins had a long career at CDC, including almost a year as the acting director in 1985. He was regaling us with some of the stories of that time over lunch. He's now the vice president for health activities at the Carter Center, where he oversees international health programs in 8 African and 6 Latin American countries, as well as the center's mental health program. We're also pleased to have with us several colleagues of Dr. Hopkins from the Carter Center, as well as staff and students from the Hubert Department of Global Health at Emory, as well as people from the CDC Foundation and the board. This is our 7th Koplan lecture, focusing on the importance of developing the next generation of public health leaders to tackle the serious global problems that our world faces today. Problems like polio, which we have come close to eradicating, and we certainly will. And guinea worm, and I'm sure Dr. Hopkins will say more about that shortly. Here at CDC, we're very proud of our 2 global public health leadership programs. The field epidemiology and now laboratory training program has been in place for 27 years and currently has partnerships with ministries of health in 43 countries. This program continues to bolster the epidemiology and laboratory skills of public health officials in developing countries across the world. We're also very proud that we've made some contribution to the fact that 90% of the graduates of the FELTPs remain in government service after their training. The Sustainable Management Development Program, which last year graduated its 17th class, which included 30 senior management fellows from 17 countries. Through Atlanta-based and in-country training, SMDP has assisted nearly 1,500 public health managers in developing countries. Rich Besser is going to introduce Jeff, and then Jeff will introduce Don. But I have to say just a little on the personal side. Don, you probably don't remember. I certainly do. When I met you, when I came to CDC in 1988, I was introduced to you by Jeff, who introduced you and said, "This is who I want to be when I grow up." He'll maybe comment on whether he thinks he's done that. Over the years, of the many things that I've learned from you, Don, one sticks out in my mind. I don't remember where we were. I think it was in Togo for a guinea worm meeting, and you said, somehow the issue came up, we were looking at some studies, and you said, after a long discussion, many people were talking, and you kind of cut through and said, well, look, before epidemiology, there was common sense, which is worth remembering. So it is now my pleasure to introduce the acting director of CDC, Dr. Rich Besser. Rich?
Thanks very much, Steve. This falls into the category of one of the really fun things I get to do as acting director of CDC. I want to join Steve in welcoming you to the 7th annual Koplan Lecture in Global Health. It's a real pleasure and honor to have Dr. Hopkins here to be presenting this lecture. He is an esteemed CDC alum. He's someone who, now that I know that he served as an acting CDC director, I'm going to be calling on for advice. He currently serves on the CDC Foundation board and is a real leader around the world in global health. He's going to be updating us on the work that he and the Carter Center have been doing to eradicate guinea worm. a disease that affects people in some of the poorest places around the globe. I think what we'll be hearing about is how this kind of work inspires hope and inspires hope around the globe. And this is a critical part of our mission at CDC. And we view the Carter Center as an important partner in this work. When guinea worm is eradicated, it's going to represent the first disease that was eradicated, not with vaccines, but using low-tech ingenuity. And I really look forward to hearing the presentation on that. It's also very fitting that he be presenting today. Sunday is World Water Day. And a lot of our work at CDC in the global arena revolves around the importance of providing clean water. And today, 2.5 billion people around the globe don't have access to clean, affordable water. About 1 billion children don't have access to clean, affordable water. And every 20 seconds, a child dies from lack of access to clean water. That's 1.5 million preventable diseases a year. And it's something we are committed to working on and eliminating. So CDC is very pleased to work in partnership with the Carter Center, with WHO and others to improve the safety of water around the globe. We bring technical expertise to that field. We assist in the monitoring and the evaluation of programs that are working on that. And we bring our voice to the forums where we participate about the importance of tackling this problem. If you didn't see the exhibit over in the Global Odyssey Center, I'd recommend that you do see that. I'm not sure when it leaves, but it's an exhibit called Design for the Other 90%, and it talks about some of the low-tech interventions that have had dramatic impact on the health of people around the globe. And this is something that we can help to share. We can help bring the message that improving health around the globe doesn't require massive investments of dollars. If you look at the dollars that have gone for things like bonuses, just imagine what that would provide to the global community and improving health around the world. Well, it's now my honor to introduce the man for whom this lecture is named, Dr. Jeff Koplan, who has been a major contributor to global health. He was director of CDC and administrator of ATSDR from 1998 to 2002. No stranger to disease eradication, having been part of CDC and the global community's work to eliminate smallpox 30 years ago. He's now Vice President for Academic Health Affairs for Emory's Woodruff Health Sciences Center. He's responsible for coordination and oversight of academic matters, including research and education in Emory's School of Medicine, Nursing, and Public Health. I just want to say that he has also provided me with incredible advice and support during the past few months that I've been in this job. He's a true friend of CDC, and I want to welcome you to the stage.
Thanks, Rich, and thank you all for coming. Thanks, Steve, for your comments as well. It's great to be back at CDC and great to see you all here, and I'm looking forward to the lecture, as are you. I've known Don Hopkins since my first days at CDC when I was in smallpox eradication program, and Don was a major player in it, having worked in Sierra Leone with major efforts there, and he's been a friend and a colleague and a mentor for all these many years. So Steve's comments earlier about looking up to Don are quite true. But he's played a very special position in our own household in a way that very few other people have. Our children always had great affection for Don and real reverence for him that I never quite understood until one day we had a guest who, in the course of conversation at the dinner table, remarked that they had done their training at Hopkins. And our daughter said to him, "John Hopkins University?" And to this day, they refuse to refer to the school in Baltimore by any other name. Their feeling is it adds stature to that school to be called by someone who's actually, people know what that person's done. Don's background is grew up in Miami, has Caribbean roots beyond Miami, attended school here at Morehouse and was greatly influenced by the leadership at Morehouse during his years there, and has many colleagues and fellow students who still remain prominent in health and public health circles. Went on to medical school at the University of Chicago and then did his postgraduate training in pediatrics at University of California in San Francisco General Hospital. Was active in smallpox eradication program. Went on to Harvard School of Public Health, where he was on the faculty and a distinguished professor in tropical diseases, and at about that time became interested in history and began to write and work ceaselessly on a book which became Princes and Peasants, Smallpox in History. It's a magnificent, if you haven't read it, I'd urge you to get it. It's been reprinted, it's out. It has both a history of smallpox, but much more importantly, the impact it's had on events throughout history in multiple continents and multiple cultures. It became a finalist for the Pulitzer Prize and has stood the test of time. Don returned to CDC, became deputy director after serving in global health roles here, and then acting director for nearly a year in 1985. For almost 3 decades, he's focused his efforts on dracunculiasis, guinea worm infestation, and its eradication, with remarkable progress being made and an end in sight. He's director of the health programs at the Carter Center, vice president for health at the Carter Center. Don brings a special mix of skills and talents, intelligence, more than intelligence, wisdom, perseverance. He is dogged in his pursuit of a health outcome or a literary outcome. He learned at Morehouse to aim for the stars, not at ground level, and in so doing has achieved those goals that most other people wouldn't set for themselves. He brings academic and analytic vigor to everything he does. He has the utmost integrity, and he wraps it all up with warmth and compassion. He has a record of great accomplishment. So he and the guinea worm eradication program will succeed, and it's an honor for all of us to have him present today, particularly for me to have him give this particular lecture. Don?
Well, good afternoon. It's a true pleasure to be back at CDC and among so many friends. Dr. Besser, new friend, Jeff, Steve. Many stories, but one reason I am very happy to give this lecture, that it gives me opportunity to return a favor to Jeff, because about 2 months after I retired from CDC, I was invited by the American Society of Tropical Medicine and Hygiene to be interviewed for some kind of series they were doing on leaders in public health or something, and Jeff agreed to be the person who interviewed me, and so that's on that series with the American Society of Tropical Medicine and Hygiene. So if any of you are curious to see what we both looked like when we had more hair, that would be a good place to go. Whenever I see Dr. Sensor, I recall my very first day at when I came back to CDC after doing my master's in public health, and Dr. Sensor put me in the planning office. My wife and I were staying temporarily at a motel downtown, and I came out here eager to be early for coming to work. I drove into the parking lot, and parking lot was full of cars, and I'm saying to myself, holy Moses, you got a whole bunch of eager beavers here at CDC, and it turned out I was a half hour late. I hadn't known that CDC started work then at 8 o'clock. The Shannon Sullivan, who's here, my assistant, found this photograph of an ivory-billed woodpecker on the internet for me. And just as I don't know why I was moved to go into medicine or international health, I also don't know why woodpeckers have such fascination for me. I subsequently read, however, that among the Yoruba in West Africa, they have a concept called ashe, which means the power to make things happen. And according to my reading, there are two animals that they feel embody that, that concept. One is woodpecker, and the other is a pit viper. Believe me, I identify much more with the woodpecker. Now, I don't want to give the impression that we have all the answers at the Carter Center, but I certainly feel very privileged to have really stumbled into the smallpox eradication program, and with it CDC. I knew I was interested in international health since before I went to medical school. I had done a little research on schistosomiasis there. But it was in the process of applying to the U.S. Public Health Service that I indicated on my application that I was interested in tropical diseases, would like to work in Africa if I could, and sent that off to PHS Washington. And some kind soul who I never learned the identity of saw that, knew something I didn't know, which was that CDC at that time was recruiting people for the smallpox eradication program. And so that person sent my application to CDC. 20 years later, when we had a little retirement thing for me here, Don Millar, who was head of the smallpox eradication program, told the story that I'd never heard of before, that the prevailing view here in the smallpox program at that time was that nothing good ever came out of Washington. And so they were looking with some skepticism at my application, but everything worked out okay. Now, so I just want to share with you a few of the things we're working on at the Carter Center, and with it try to convey some sense of how we work, why we do what we do. As many of you know, the motto of the Carter Center is waging peace, fighting disease, and building hope. One of the most exasperating experiences I've had on several occasions is working intensively in the guinea worm eradication program to hear people say, well, you know, we hope next year we're going to have that, or we hope next year we're going to have this. And that is why I have that first quote up there, that you don't make things happen by hoping that they will happen. Making things happen can help build hope among people, and so hope is a product, not an intervention. And as you see there as well, the Carter Center believes in helping people improve their own lives, not spending time on unclear objectives or non-productive contracts. The non-productive contracts refers to certain agencies that contract with other groups for building water supply, borehole wells and such things in communities, but then don't bother to monitor that. And so the agencies who will remain nameless brag about the amount of money they're spending on water supply, but don't look to see how many of those wells, they're spending money on water supply in the name of guinea worm eradication, but don't look to see, A, how many of those wells are in villages that have guinea worm, and B, how many of those wells have hand pumps on them and are actually working. So our idea is get to the bottom line. And similarly, as President Obama said in his inaugural address, we are focused not on what's a horizontal or vertical program or this, that, or the other, but what works. I once encountered a senior official at a bilateral assistance agency who was trying to convince me that the real problem was that all people, those of us working in the so-called vertical programs, that the problem of villages was one day the diarrheal diseases people come out, and next day the immunization people come out, next day the guinea worm people come out. And I said to her that in my experience it was a fortunate village that had that problem, that the usual problem was nobody coming out. And if I try to imagine myself in the villager's place, I'd much rather have that problem than the problem that most villagers have in regard to people helping them. And so we took, you realize the Carter Center has the piece, the political stuff, and then we have our health programs. And so we tweaked the Carter Center's motto to create this motto on the health side of fighting disease and building hope at the grassroots. Now, if a picture is worth 1,000 words, to me, action is worth certainly a lot more than talk. Carter Center has been involved in the guinea worm fight since 1986, and we've added onto that several other things since then. Thank God for the people led by David Molyneux and others at Liverpool and elsewhere who had this concept of gathering up some of these neglected diseases and showing how important they were collectively, how approachable they were collectively, compared to malaria, tuberculosis, and AIDS, HIV, which was getting most of the funding. So that's been a good thing, but in the process we've had a lot of folks now who are suddenly NTDers, one can call them. And so I just like this concept of we at the Carter Center have been dealing with neglected diseases for some time. I'm going to talk just a bit about leadership, partnership, and eradication. This, as you can well read, is Dr. Tedros Ghebreyesus, the Minister of Health of Ethiopia. I've been in this international health business now for 41 years in a few months. And this is one of the 3 most effective ministers of health I've ever met, and I've met a lot. One was Dr. Julio Frank, now Dean of Harvard School of Public Health, formerly Minister of Health of Mexico. The other was the late Professor Ransom Kuti of Nigeria, for whom I thank God many times that was the man who was Minister of Health in Nigeria when I was still at CDC, and we were starting to try to get this guinea worm eradication program going, not just in Nigeria but elsewhere, because that minister and Nigeria were very well respected. And even though he was not a verticalist, instead he started out a different way, he saw the value of the guinea worm eradication program and pushed it, not just for Nigeria, but with other countries doing at the World Health Assemblies and on similar international occasions. And at other levels, we've had, if I'm thinking of 2 of the guinea worm eradication national coordinators in Africa, of the 17 countries affected, where if we could have cloned either of them and put them in the other 15 countries, the guinea worm story would be over. It would have been done. And it's always interested me to see the difference in just how some people take to that. It's the way God makes us, I suppose. But it happens also at village level, where some people simply will move right away, and others are slower, and some don't move at all. But this minister was there, and it was 3 years ago. Dr. John Hardman, then executive director, now president of the Carter Center, and I sat down with him, and he asked us, this minister, to get involved, the Carter Center, to get involved in helping Ethiopia in Ethiopia's malaria eradication effort. But as minister, he had come into office, and most ministers come in and learn what their budget is and try to figure out how much they can do with that budget. This man came to office, decided what were his priorities, and figured out how much he needed to do what were his priorities, and went and successfully competed for that within his own national government, number one, which is very important, and then with other outside partners. And so he requested the Carter Center's help. He was by far not the first minister to request Carter Center's help on malaria, but he was the first one to do that successfully. And part of the reason was that in October 2005, this is about 4 or 5 months before we met with him, our International Task Force Disease Eradication at the Carter Center, which I chair, had for the first time reviewed the problem of malaria, mainly in Central America and the Caribbean. Now, as I said a few minutes ago, many people have been asked Carter Center to get involved in malaria work, and we're often asked, how do we choose the problems that we get involved in? We look for bad diseases, there are lots of those. Bad diseases that we can do something about, there's still plenty of those. But then neglected bad diseases that we can do something about, where we feel that adequate effort is not going on. And then, of course, we have to be able to raise money for it. And so we had refused to get involved in malaria because our view was that a lot of other people were working in malaria. We weren't needed. But then we reviewed this problem and looking particularly at that time at bednet distribution, and realized that there were a lot of people working on it, a lot of money being spent. Bed nets were not getting to the people that needed them. And so that was one thing that happened. And then around the same time, Dr. Ben Blackburn and colleagues here at CDC, working with some of our colleagues in Nigeria, were able to show where the malaria program in Nigeria is having trouble distributing their bed nets, asked us whether some of the river blindness people working with us in Nigeria, village volunteers, could distribute bed nets in addition to the other things they were doing. And they were able to show that in a very short period of time, those village volunteers were able to increase 9-fold the prevalence of bed nets in the communities where they were working. So we had that rattling around in the back of our heads as well. We walked into Minister Tedros' office, and he asked the Carter Center in February 2006 to get involved in malaria. I can't tell you how much I cringe internally as well when you go to a minister or somebody else's office and the first thing they're saying to you, whether at CDC or us at the Carter Center, is, what can you, Carter Center or CDC, do for us? Not, this is where we want to go. We've gotten our resources together, and can you help us with a piece of this? Well, that's what Minister Tedros did. And here you can see in that yellow bar there in 2007, he asked us to help evaluate the malaria program and monitor the malaria program there. He asked us if the Carter Center would buy 3 million bed nets. They estimated that they needed 20 million bed nets. He had already gotten 17 million bed nets. Can you, Carter Center, help us with these final 3 million bed nets? And we also agreed to help distribute those bed nets in the areas of Ethiopia where we were already working on the trachoma program and the malaria program, again with village volunteers. And so you can see that that was a critical 3 million bed nets, but it was part of a much bigger piece with other players and with very important leadership. Here you have in the areas the districts and regions that are colored in there, just in yellow and green, the areas where we were assisting with trachoma, in blue and green, the areas where we were assisting with river blindness, in all of those areas, village volunteers working at the village level. And so we helped to, the Carter Center agreed, and Minister Tedros speaks to this day of how fast we were able to move compared to his experience otherwise in getting our board to approve the idea of the Carter Center purchasing 3 million bed nets and getting them in Ethiopia to help to distribute them. And you see there, we distributed 3 million bed nets in the areas where we were working. You can see that the baseline data showed prevalence of long-lasting insecticidal bed nets of 19, almost 20% there, going up to 68.3%. You can see also parasite prevalence being reduced from 4.1% to 0.3%. Now that's malaria in Ethiopia is unstable, and we're working to continue to monitor all of this and see whether or when Ethiopia will have any further epidemics of malaria. But the overall picture of this is that when you looked at these abysmal graphs showing the proportion of population in malarious areas protected by bed nets in Africa, before this minister, Ethiopia was next to last in Africa. And as a result of this initiative, Ethiopia was number 3. And with a population of 75 million people, Ethiopia's population was several times the population of the two much smaller countries that were numbers 1 and 2. And I ask you, those of you at least of a certain age, to think back at how long people had been waiting for bed nets, not just in Ethiopia, but in other countries. One thing that's been new, of course, is technology to have these long-lasting bed nets and insecticidal bed nets at that. But still, it's a travesty that people have had to wait this long, and now suddenly, finally, happily, belatedly, the world has woken up to the fact that people really need bed nets, that that's a good thing, and that it can help a lot. Now, a few words about partnership. This is Nigeria. In green are the 9 states where the Carter Center is assisting. We inherited those 9 states when we absorbed the River Blindness Foundation in 1996. They were already working on river blindness in those areas. As soon as we became responsible for these 9 states, we said, well, we're already doing with village volunteers, they're already doing distributing mectizan for onchocerciasis, river blindness, and doing health education. The mectizan is a safe oral drug that can be administered to people en masse. Why not also use the same volunteers to also distribute mectizan and albendazole for combating lymphatic uriasis and praziquantel for combating schistosomiasis in the same communities that need them? And so we began doing that. And we have, with a lot of Nigerian colleagues and other Carter Center colleagues, a paper coming out probably in next month's American Journal of Tropical Medicine and Hygiene that will include these and some of the other, a few other things I'm going to show you, in which we sought to put in one place what Nigeria has done, is doing, will do, intends to do against dracunculitis, guinea worm disease, onchocerciasis, river blindness, lymphatic filariasis, and schistosomiasis. Now, you need to know also that a lot of people from this country and other countries outside of Africa are afraid of working in Nigeria for all kinds of reasons. And sometimes we are afraid of working in Nigeria too. But the map there in black and white is from the first Nigerian village-by-village search for guinea worm disease, which they did, as you see, in 1987 and 1988. Craig Withers, who is our director of the Office of Program Support at the Carter Center now, was our first assignee to Nigeria. And within about 3 months of when he landed in Lagos in Africa for the first time, Nigeria was conducting a village-by-village search for guinea worm disease. The Carter Center not having one vehicle in Nigeria and not all of these other resources. I remember Craig telling me about how some of the other international agency representatives were incredulous at this bold intent. But this was, I'm sorry, this map was earlier from when we did a questionnaire of people and then refined it. We did a questionnaire of people the year before and then refined it with this village-by-village information. But I can tell you that people knew in Nigeria, many people knew in Nigeria about guinea worm disease, but when this map was published showing that guinea worm was distributed throughout the Nigerian Federation, that began to create a lot of political pressure and get action on this program. Similarly, APOC and the WHO and others, with our help and many other NGOs, as we'll see in a minute, created the map for onchocerciasis in red, the areas that require mass treatment. And then you see the map of lymphatic filariasis there in the lower left, and in gray are the 4 states that still remain to be mapped this year, and some of them may have been mapped already. That was as of the end of last year. And then the incomplete, very incomplete map of schistosomiasis, which is much more difficult to map. But the point being that Nigeria has some sense of where it was, where it is on all 4 of these problems. Here you see the amounts of treatments with albendazole and with for onchocerciasis, with mectizan for onchocerciasis, albendazole and mectizan for lymphatic filariasis, and at the top a little bit for schistosomiasis. But the point is that for 7 years, Nigeria, for all of its problems, with the help of a lot of NGOs, not just the Carter Center, has been treating more than 3/4 of the population in Nigeria that need treatment for onchocerciasis. And here you have an example of some of those partners. In the early days, we were really scrounging for partners and being turned down by most for the guinea worm eradication program, but many other folks were interested in onchocerciasis at the beginning, mainly because it had to do with blindness, and there were from the beginning a lot of other partners. And I would underscore the fact that partner numero uno was the government of Nigeria at its various levels. And I would just, as a sidebar, mention this as another pitfall where often folks come into countries and it's as if the outside agency is sovereign, not the government concerned. We also did have in the guinea worm eradication program, especially in the south of Sudan, a lot of NGO partners that once they realized, as the Nigerians had, how big a problem guinea worm disease was, they also got involved. And we like to document our impact, the impact in this instance in Nigeria, as I mentioned, with lots of other partners, but you just see there that Nigeria now may in fact have already eradicated guinea worm disease. We won't know until about this November, but Nigeria started out with, they counted over 653,000 cases in 1988-89. Last year they had 38 cases. 36 of those cases in 2008 were in January and February. And January, February this year, 1 year incubation period, no cases in Nigeria. And Nigeria tells us that Nigeria contained all 38 of those cases in 2008. And if you knew the guy who was telling us that, I would just say that Dr. Ernesto Ruiz and I both feel that we have more confidence in this guy than almost anybody else. And so I think Nigeria has really, really done it. But now, so guinea worm is gone or almost gone in Nigeria, but people are still suffering from onchocerciasis, lymphatic filariasis, schistosomiasis, and a lot of other things. You've already seen they've also had a treating. More than 3/4 of people need treatment for onchocerciasis. In these various sentinel groups, you see dramatic impact on one sign or symptom or another for the other 3 diseases. And the point we're trying to make with Nigeria now is that, all right, you've done it or almost done it for this one disease. Let's get on with it with these other problems as well. And we'll help as we can. But we have a new Minister of Health in Nigeria now, and hopefully he'll turn out to be a true heir of Professor Ransom Kuti. But here you see the proportion of the population in Nigeria that's being covered by the appropriate preventives for the 4 diseases. And so you see there's a good bit of work still to be done. But think also that in guinea worm, where one main intervention has been to have these village volunteers, train them to hand out cloth filters, to do health education, and to report cases monthly, where as a result of that single disease, you get, in the case of Nigeria and in Ghana, each country, over 6,000 villages reporting monthly to the capital city, more or less, high percentage of them. So you have a good surveillance system that could be adapted for other uses. And you also have village volunteers trained to do health education, and they can do health education about other things, but they're not doing health education about guinea worm disease. In the case of river blindness, you have village volunteers trained to hand out this mass drug administration. And as I've already mentioned, we helped Nigeria in 2 states adapt them to do this, not just for river blindness, but for schistosomiyasis and lymphatic filariasis as well at the same time. I'm not going to talk about the trachoma program to any extent here, but know that especially in Ethiopia, part of the intervention in trachoma has been to help communities mobilize themselves to build the trains and use them, of course. And if you get people doing that, again, you've got a lot more impact on a lot more diseases besides trachoma, just providing safe drinking water for, in the name of guinea worm disease, protects against a lot of other things as well. And so you have this nexus between eradication and integration. We started out, Carter Center in Nigeria, helping them with this guinea worm eradication program. Here and in Nigeria and Ethiopia especially are poster children for integrated programs using same village volunteers to work against more than one disease. And these are important concepts going forward. Now, to turn finally to a few words about eradication. This is a very seductive word, and with reason. It's very attractive to donors. I once heard another senior official of an international assistance agency apologizing that they were working in lamenting the fact that they couldn't do more work in broader programs because, he said, donors like eradication programs. They don't like programs where you're doing these broad kinds of things. So eradication is attractive to donors. But setting that aside for the moment, where you can eradicate something, it's certainly, in my view, we certainly ought to do it because of the infinite benefits, economic and health benefits. And it's just such an inspiring thing to be able to do. And having been inoculated that way in the smallpox eradication program, among my greatest pleasures now is seeing other young people have this kind of experience, albeit much more slowly, with the guinea worm eradication program. So I mentioned before our International Task Force for Disease Eradication. When we looked at malaria in 2005, the next year we looked for the first time at what we might be able to do about it in a few places, and we looked particularly at this island of Hispaniola, including Haiti and the Dominican Republic. And you can see here the broad data on the distribution of these 2 diseases on that island. Now, I should mention that that island is the only repository of malaria remaining among the islands in the Caribbean. And it is the repository of 92% of all the lymphatic filariasis in the entire Western Hemisphere. And you can see that Haiti is more affected by the other. And the fact that it's an island makes it an easier setup for elimination. And I can only hint at how close one of our Task Force for Disease Eradication members came to having a stroke when he realized how certain agencies and governments were beating on Haitians to sell bed nets to population of the poorest country in the Western Hemisphere. So one of the recommendations we made out of our little Task Force Disease Eradication was that the world should help Haiti and the Dominican Republic to get rid of both of these diseases altogether. Know also that this is I'm going to come to some of the other rationale for that, but the Carter Center, we made this recommendation of the International Task Force Disease Eradication, which is more than the Carter Center. It's a dozen international experts. But then nothing happened for a couple of years or so, and so we decided to put a little money into it and try to help get those two governments working together. Historical antagonism on the island won't get into between two governments, but we put a little money into it starting last year and got one of your alumni, Dr. Phuc Dinh, to go down as our consultant. President Carter wrote the heads of state. We sent money down. They began having bilateral meetings, began distributing bed nets that we sent down with the equipment and training people and things. And now they are doing, they've also persuaded Haiti to make treatment for malaria free as it was already in the Dominican Republic. And now they're seeing, as they're testing people in this border community that we're assisting, it's one community on the border, 2.5% of people tested positive for malaria on the Dominican Republic side of that dual community, 18% testing positive for malaria in Haiti. But it had been estimated that an outbreak of malaria on the Dominican Republic side a few years back cost the Dominican Republic on the order of $200 million in lost revenue from tourism because of warnings to would-be tourists by their governments against going there. So an important economic problem. Obviously, people are suffering and too many dying. Export of cases to the Bahamas and Jamaica, probably here to mainland North America as well, potentially from that island. And I've already mentioned the concentration of those two diseases on the island. Lymphatic filariasis especially is just wound up as tightly as it can be with poverty, cause of poverty, consequence of poverty, especially on the Haitian side, as you've seen. And then we have also global campaigns being in the air, let's say, for lymphatic filariasis and malaria. So there's every reason to help those two governments collaborate and get rid of that disease. And I'm hoping that we're going to be able to do that with this little money and putting a lot more attention on the opportunity that's there to do something very positive. You will recall that just as we were starting this initiative, however, that same island was pounded, I forget now whether it was 3 hurricanes in succession in the course of a month or 4. And so now to when I was here at CDC, I used to call my dessert, which is guinea worm eradication. The younger folks should know that this initiative started here at CDC October 1980. And among the couple of things I hope to do with whatever breath I have left after guinea worm is gone is one will be to write up this story. You cannot retrieve now very easily what it was like in those early days. And I think if people are inspired by the guinea worm eradication program, now that we're so close, they need, and I want them to have, the vicarious understanding of what it was like in the early days when countries were not reporting malaria, when ministers of health, when countries were not reporting guinea worm disease, when ministers of health didn't know what it was, when international agencies or some people in international agencies were scornful of the problem. I'll just tell you one anecdote. I was several years on representative of CDC on the U.S. delegation to the World Health Assembly. 1986, my last World Health Assembly, when we, U.S. delegation, meaning CDC, me, were pushing for a resolution to include the words guinea worm eradication, trichonculiasis eradication. At that World Health Assembly, at that time, I think the World Health Organization had either 4 or 5 assistant director generals. Rafe Henderson was not there then. This is before his time. At one point or another during that World Health Assembly, I had 3 assistant directors generals, not they weren't independently, but individually come up to me to try to persuade me to back off and wait 1 year or more to push this resolution for guinea worm eradication. There was a Russian guy who was in charge of infectious diseases, there was a French guy who was in charge of vector-borne diseases and environment, and there was the American who was in charge of administration and the assistant director general. And I'll stop there because we're still working with WHO. But I should add, have very good collaboration now with WHO. WHO is a different set of people now, and of course, guinea worm is a lot closer to eradication now. But there you have it, essentially on one slide, where we've been and where we are. Dramatic reduction in number of cases as of last year, a dramatic reduction in number of villages, and in the number of countries. And here you have, in a different way, the 14 of the 20 countries that have already broken transmission, the 6 remaining countries, and the distribution of the disease in those 6 countries. I hope we have a few minutes for some Q&A, but I'll just leave this there, except to point out that I've already told you about Nigeria having started out with 653,000 cases. Ghana, the same year, about 1989, counted almost 180,000 cases. They are now, last year, at 501 cases. Uganda in 1991-92 counted 126,000 cases. Uganda has been at 0 since 2003 as a result of strong government support. And the final thing I'll leave you with in regard to this is that I believe that after guinea worm eradication will come lymphatic filariasis, and after polio, measles. I want to acknowledge, I don't do all of this work, obviously. At the Carter Center along, Chandler Sullivan, Ren McClintock Doyle, Dr. Ernesto Ruiz in charge of our guinea worm eradication program now, Dr. Paul Emerson in charge of our trachoma program, Frank Riches in charge of river blindness, lymphatic filariasis, schistosomiasis, and malaria. Craig Withers, the Director of Program Support. Thank you very much.
Well, Don, thank you very much. That was informative and inspiring. I actually told some folks last night, I asked them, are you going to come to the lecture? And one person said, well, I don't know, I'm kind of busy, I'm going to come. And I said, this will be the best 60 minutes of your day, I guarantee it. And I think he's here in the auditorium. We've got time for a few questions. The microphones are there, or depending on if you're sitting up front, please press the microphone in front of you. Yes.
Dr. Hopkins, thank you very much. Very inspiring talk. I know there are issues that you didn't talk about that you could talk about. One of them was in bright red on the top of the last slide that you showed. Trying to do this work in areas of conflict and the implications of not being able to eradicate in certain areas of conflict as to what the ramifications of that might be in neighboring countries, et cetera. Can you speak a little bit more about those challenges and what might be hopeful in the opportunities there?
First, a caveat. I'm a congenital optimist. But I think real at the same time, and I would just recall for you that during the smallpox eradication program, we had a civil war in Nigeria. We had what was then East Pakistan war with that broke away as Bangladesh. And where was the third civil war? Oh, Sudan. That was Sudan, East Pakistan, and Nigeria. Also a civil war. So we got around it. And smallpox was eradicated in Sudan during a 10-year hiatus between the two different phases of their civil war. You probably know President Carter negotiated in 1995 a Guinea worm ceasefire, so-called, in Sudan during that civil war that wound up being almost 6 months in duration, which allowed us and the Sudanese and others to start that Guinea worm eradication program with the Comprehensive Peace Agreement in January 2005. As a result of the ceasefire in 1995, Sudanese authorities and ourselves were all surprised we were able to do as much, because they weren't finding everywhere, thank God, all the time in southern Sudan. So a lot of work was done. And when that happened, Sudan was ready to roll, and they have a very, very good national coordinator, but very, very bad infrastructure and a huge land down there with all kinds of impediments. I hope and pray every day that this agreement holds. I don't want them to start fighting ever because of the consequences of that again. But if they're going to start fighting again, I hope that we can get rid of Guinea worm before that's done. Sudan has been the poster child for insecurity as a part of the Guinea worm eradication program, but there have been many, many other places. Nigeria, Ghana, Ivory Coast has a civil war right now. Some areas of Nigeria, there have been plenty of this, and you simply have to work around it and not put people at risk in the middle of that, but back off of it and just wait if that's what you have to do. In this instance, waiting is obviously an issue not just for Sudan. I think Sudan has 8 neighboring countries, and all of those will be on alert. And that's expense, because you don't want a sporadic case to walk across the border into Ethiopia, so Ethiopia has to keep its guard up as well, as long as there are these cases there in the south. So I'm hopeful, but we shall see. Over here.
Thank you very much for the interest in your presentation about Haiti. I'm from Haiti, and I'm well aware of the malaria and filariasis over there. I don't know if I've missed that part in your presentation. Does the Carter Center have a current program running in Haiti for either malaria or filariasis? If not, is there any plan in the near future to have something? Yeah.
The answer to that is yes and no. Mostly no. We are putting money, equipment, and a consultant in Haiti and Dominican Republic at Ouanaminthe on the Haitian side, Dajabon on that community at the border. And the intent is to use that as a way of getting the rest of the world, the other donors, and the 2 governments concerned to focus on this problem. And we made that commitment, a few $100,000 for 1 year, October last year to October this year. I'm hoping we'll maybe be able to get President Carter to go down there at some point. We had him write the 2 heads of state, as you may have noticed there. So what we're basically trying to do is to get the 2 malaria and mainly malaria on that border, get those programs working together, learning from each other, but use this as an opportunity to shame the rest of the world, to do what should have been done a long time ago, and help those 2 countries get rid of these 2 diseases. Yes. This will be the last one.
Okay. Yeah, Dr. Hopkins, Rana Haji bacterial diseases and CIRD, thank you very much for a very informative lecture. I'm actually very curious in learning more from you about focusing on what works and what works in developing country settings when it comes to implementing public health interventions. This is obviously the most difficult part of our job, and often it's not good epi or good laboratory support that's going to help us with implementation. I was very interested to hear about your earlier efforts in Nigeria and the importance of advocacy and having a good champions at the country level who are willing to actually take on the cause, and not only in their own country, but sometimes advocate to the other countries. And in addition to not being also discouraged by the various bureaucratic hurdles, whether, we call it vertical programs or other things. We have had a similar experience recently. CDC was part of a large program to implement hip vaccines in developing countries was a Gavi-supported initiative, and we were very discouraged by various groups when we started that this is not going to work. This was 4 years ago, and we went from 19 countries that introduced hip vaccine to 67 countries within less than 4 years. And, I have to admit we were kind of a little bit naive getting into it, thinking that we were very optimistic we're going to make things work. But what really worked for us was the things you mentioned, the commitment, the high-level advocacy at the decision-making level, and the good communications and relationships at the country level. And I'm just very curious to hear more from you about, the things that you really think helped making these things work.
I would just say a couple of things quickly. One is, among the most important things President Carter did for the Guinea worm eradication program was to recruit in Nigeria General Gowon, and in Mali, then former head of state, General Amadou Toumani Touré. And both of those have been very, very powerful advocates for this disease. But I'd also say that, especially for people coming from North America, I have to say that you have to start with respect for this local culture and people. I can't tell you how many times I've seen, and I cringe when you hear expatriates talking among themselves in some of these countries, or just the presentation when you go into a community. And however poor they may be, I can tell you that people pick up on those clues instantly, and they don't like them any more than any of us would. And so some programs are dead in the water before they even start because of that. The final point I would make is what I call the Hopkins River principle. The respect one is the Rodney Dangerfield principle, but this one is don't spend your time beating your head against a brick wall. I've already said in the early days there were some agencies, some individuals that didn't want anything to do with Guinea worm eradication program, some countries. Go with the ones who are ready to go and come back to those when you can, and work with those. I could say a lot more on that, but I'll stop there for as far as principles go.
Once again, can we have another hand? Well, folks, thanks very much. Next year, another good speaker. We promise.